guys, this is Zach. Today we're going to be talking about drugs that are affecting the sympathetic nervous system. And they're known as adrenergic drugs. We are going to go through a couple different things in this video. We're going to start off with receptors of the sympathetic nervous system and what they're in charge of controlling throughout the sympathetic nervous system, and how when they're stimulated, what kind of response do they have. Once we get through all that, once we have a good solid understanding about all that, we're going to move into the drugs that we've been assigned this week, and we're going to assign them to the different receptors as either an agonist or an antagonist. So we'll get into all that here in just a little bit, but first let's talk about the sympathetic nervous system and how your body stimulates or inhibits the fight or flight response. So the sympathetic nervous system is a branch of your autonomic nervous system that autonomic, you cannot really control that. It's one of those things that your body is going to do whether you like it or not. So with your sympathetic nervous system, it is designed to respond to stress, and typically it responds to stress by increasing things like your heart rate, increasing your blood pressure, your respiratory rate. You're going to see bronchodilation in the lungs to allow for free airflow, making sure that it's got an open space that it can flow through, so then whenever you breathe in, you're getting more air in, exchanging more oxygen for carbon dioxide, all that good stuff that we hit in anatomy and physiology. Your circulation is going to be one of those things that it's affected in a huge way. You're going to notice with sympathetic responses that your peripheral or your vasculature that is away from the core mass is going to be kind of shunted. Your vascular system is going to shunt blood towards your core. That's what we call vasoconstriction in the periphery. This allows for the blood to be used in essential functions when you're dealing with a stressful situation. Centrally, when that blood is shunted from the external to the core, you are going to see a vasodilation. Those blood vessels in the core and leading to muscles, particularly the muscles that are going to get you the heck out of Dodge or fight whatever's going on, those are going to expand. Again, we're allowing for easier flow to and from the essential pieces of your body in that stressful situation. One of the ways that your body focuses on staying focused is by acting on your pupils. Your pupils, in a sympathetic response, are going to dilate as well. Reason behind that, it allows more light in. It allows for your brain to take in more information, so it can use that in either the fight or the flight response. Couple things are going to be decreased when you are dealing with the sympathetic response. The big ones are going to be your GI motility. So your gut isn't going to push things through and work on digesting at that very moment, because it's got to devote its energy to other things. So you're going to notice an inhibition of things like peristalsis. Additionally, your saliva glands are acted on by one of the receptors we're going to talk about here in just a minute, but it is going to restrict the creation of saliva, and so dry mouth is associated with a sympathetic nervous response. Additionally, your urinary output is going to be decreased. So your ureters from your kidneys down to your bladder, those are going to be kind of constricted. Your urethra is going to be constricted, so you're not worried about voiding fluids from the bladder while you're dealing with a stressful situation. So when the sympathetic response happens, it's being caused by a dump of things like epinephrine, norepinephrine. This is actually what a lot of people know as adrenaline. Epi and norepi, they act on these particular receptors to stimulate these responses. So let's go ahead and head through the receptors and what they do, why they work, and we'll go from there. So let's go ahead and get into the receptors involved in the sympathetic nervous system. I've got this broken down into excitatory receptors and inhibitory receptors. It's going to make a whole lot more sense here in just a minute, but what you need to know is that all of these receptors, when they are stimulated, they're going to have different responses throughout the body. So let's go ahead and get started. I'm going to go through the excitatory alpha 1 and beta 1, and then we're going to go through alpha 2 and beta 2. These again are the inhibitory or the relaxing, and we'll get to that here in just a minute. But let's start with alpha 1. So alpha 1 is in charge of your vasculature as well as smooth muscle throughout your body. When you think of your GI tract, it's all made of smooth muscle. When you think of your urinary tract, it's particularly made of smooth muscle. And so that's when we end up with things like the decrease in the GI motility as well as a decrease in the urinary output, because we end up having those muscles kind of contract a little bit to hold things where they are, especially when you're thinking about the urinary tract with the urethra, or for men, the prostate assists a lot with keeping that urine held in. It just kind of clenches that down a little bit to keep from letting fluid out. Same thing happens in the ureters from the kidneys to the bladder. You're going to notice that they kind of constrict and reduce the amount of flow from the kidneys into the bladder. So the vasculature is super important when you're talking about things like blood pressure. What happens with the vascular system is the peripheral, or the vasculature that is away from center mass, is actually vasoconstricting. And it does this, the body does this to shunt blood back towards the core to be used in essential functions. And so when we do that, it's got to go somewhere, and your core isn't used to holding all that extra blood. So one of the reactions that's stimulated by alpha 1 is a dilation of the vasculature in the core, or the central vasculature. So that is going to do some things like raising the blood pressure. That is the raising blood pressure is attributed to alpha 1 as well as beta 1, but we'll get to beta 1 here in a second. The last thing, one of those little nuanced things for Dr. B's class that we really didn't hit on much, but it's a good thing to know, is that alpha 1 is also in charge of a lot of the glands throughout the body. So salivary glands are one of the big ones, because dry mouth is associated with a sympathetic response. And so when alpha 1 is stimulated, it's saying, whoa, 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 hold up. We need to stop with the GI movement. We need to stop with urinary output. We need to stop devoting energy to things that are non-essential for this situation right now. So it also is going to be cutting off your saliva. Because it's one of those things, it's not really needed at the moment. We don't need secretions that we can, ultimately get choked on, or it's one of those things that the body recognizes is not necessary for that time. So we end up getting a decrease in the salivary production. Let's go ahead and move on to the beta 1. The beta 1 is really interesting because it works on the ionotropic effect of the heart. So by ionotropic, you should be thinking rate and contractility. So how fast the heart is pumping, or your heart rate, and how hard the heart is pumping, which is associated with your blood pressure. Obviously, too high of a heart rate, doesn't matter how hard your heart's pumping, it really can't get blood filled back up to pump out into the rest of the body. But when beta 1 is stimulated, you will notice that it's acting on the SA and AV nodes within the heart to affect the rate, particularly speed it up. And it's also going to affect the myocardium in the heart. So it's telling those muscle fibers you need to clench harder, and it's going to push harder to get that blood out of there and off to where it needs to be. When I was mentioning earlier about the blood pressure, these two work hand in hand to raise the blood pressure. So you'll see drugs that act on both alpha 1 and beta 1 to help drop the blood pressure. Or you might need to raise the blood pressure by constricting vessels, which we'll talk about with a drug called Levophed or Norepi, and you don't want to increase the heart rate. So that would be an alpha 1 agonist and has no effect on beta 1. But again, we'll get into the drugs here in just a second. That's just one of those kind of examples moving along. With pharmacology with Miss B, or pardon me, Dr. B, she doesn't particularly care right now at this very second about the alpha 2. What you need to know about that right now is alpha 2 actually has a calming effect on the central nervous system. So we can go ahead and gloss over that, but know that for when we get up to the cardiology drugs, drugs that affect blood pressure, that's going to be kind of important. Okay. The last one that we're going to talk about is beta 2. When you're trying to think of how to set this all up and how to understand and remember, which one goes where, just know beta 1 goes with the heart because you have one heart. Beta 2 goes with the lungs because you have two lungs. So beta 2 is associated with the respiratory rate as well as the bronchodilation to allow for air to move into and out of the lungs more freely. Again, if you have a smaller tube and you try pushing air through it, it's really not going to be able to move as much air in X amount of time as that same airway expanded. So this one is super important, and you might be thinking, well, how does that have an inhibitory effect? Well, it's a relaxation of those airways. So it is, instead of contracting and spending more energy on it, it's actually relaxing. So beta 2 is dedicated to the respiratory rate. So we'll get into drugs that affect these in just a second. But take a minute, look over this, review it, understand it before we move forward, because if you don't understand what is working where, then you're not going to understand what drugs are affecting what and why. Okay, let's go ahead and talk about the drugs. This is the part that not a whole lot of people look forward to, but once we understand what each one of these receptors does, then putting it all together and connecting those pieces to that puzzle start to make a little bit more sense. So if you don't fully understand what's going on, I would highly suggest going back, re-listening to either the lecture, or maybe if you want to back up and listen to this video a little bit more. Maybe there was something that was missed, or something that Dr. B can explain a whole lot better than I can, because she probably did. But we're going to get into all this, and before I do, let's hit a couple of key terms, key things I'm going to be saying frequently throughout the rest of this video. So let's go ahead and hit agonist and antagonist. So an agonist is something, we've hit it several times before, particularly the CNS lecture. We hit it in the intro to pharmacology lecture. So we understand that anything that is an agonist enhances the effect of the receptor that it is acting on, or the things that the receptor is in charge of. So we'll get into examples of that here in just a second, but let's go ahead and move on to antagonist. So an antagonist is something that inhibits or blocks the effect of that particular receptor, or the things that receptor is in charge of keeping control of. So another thing you're going to hear me say quite a bit is selective or non-selective when it comes to these particular drugs. So a for instance of this is tamsulosin. So tamsulosin is a selective inhibitor of alpha 1, or the alpha 1 receptor. So when I say inhibitor, or antagonist, or blocker, those are all going to mean the same thing in this context. So tamsulosin is a selective inhibitor or blocker of that particular receptor. And so when you're blocking the effects of something, you have to take a look at what the original effects are that it's blocking. So in the case of alpha 1, we know that it affects the blood vessels, it affects the peripheral and central vasculature. It affects things like glands. The example that I gave earlier was salivary glands. So just understanding that a selective inhibitor is attempting to activate only the one that it is designed to. So tamsulosin, because it is an alpha 1 antagonist, it is aiming to only activate the alpha 1 receptor. And for the most part, it does a pretty good job. So the next one is non-selective. Non-selective is one of those where it has the potential to hit either one of a particular receptor. So if you have a non-selective beta 1 antagonist or beta blocker that's non-selective, you have the potential to act on both of these. We'll get into one example of that here in just a little bit when we talk about beta 1 and beta 2. But just understanding that it has the potential to hit each one of those receptors. Um, so next term I'm going to be using a couple times is catecholamine. Catecholamine is it's a term used to explain or to group epi, norepi, and dopamine. So epi, norepi, and dopamine are catecholamines, and catecholamines for this, they stimulate sympathetic response, or rather than stimulate, they mimic. They have a sympathomimetic action on the sympathetic nervous system. So if you're breaking that down, sympathomimetic, sympatho or sympathetic, mimetic sounds a whole lot like mimic. So it mimics the effects of the sympathetic nervous system. And I think that's all of our terms. So let's go ahead and move on and start going over the drugs. You'll see that I already have some stuff laid out. Let's go ahead and just start with epi. Epi is the one that you can count on as an antagonist for all of these. This is including alpha 2. You know that epinephrine is going to act on alpha 1, alpha 2, beta 1, beta 2 in their respective action class, if you will. So with alpha 1 and beta 1, epi is going to have to increase the stimulatory effect that they have on organs, on tissues, on the sympathetic response in general. So it's going to enhance that. A good example of using epi to do that is with anaphylactic reactions. So with anaphylactic reactions, a couple things that the big thing that you need to know is that the airway typically is compromised, or has the potential to be compromised rather. So epinephrine is given to do a couple things. It's given to increase the blood pressure. It's going to control your smooth muscle by contracting it, keeping everything in place like we talked about in the GI and urinary systems. And it's going to help stimulate the sympathetic response all over. So then you get increased heart rate, increased blood pressure, which we see through the constriction of peripheral vessels, dilation of central vessels. We end up affecting the ionotropic effect of the heart with B1 because it is agonizing B1. So it is pumping faster and it's pumping harder. And then with B2, whenever we are agonizing it, remember that B2, alpha 2 and beta 2, they both have a relaxing effect. So in this case, you were thinking, as far as the beta 2, you're thinking about the lungs. What's it relaxing in the lungs? It is relaxing those airways, the bronchioles, the bronchi, anywhere that the air travels through, it's opening that up, and it's allowing air to move a little more freely, so that respiration, the transfer of carbon dioxide and oxygen in the tissue in the alveoli can happen effectively and efficiently. It also so epi, going back to alpha 1 and the way that it assists with the airway is when you have that anaphylactic reaction, you have the potential of intense swelling in the oropharynx, back even further sometimes, but tongue swelling is one of those things that you can see. Um, you can also see the tissue leading down to the trachea internally can swell up as well. And so by relaxing the smooth muscle, so the muscle, the tissue leading to the trachea, the tissue, you know, all throughout the GI tract, um, by stimulating this, it's going to get it to um, contract and give a little bit more space for air to move through. At least that is my understanding of that. If I'm wrong, please do me a favor, comment it under the video and tell me. I would love to hear that. But let me know where I'm wrong. If there's anything throughout this lecture that you have heard that you think I didn't explain well or is wrong, please let me know in the comments below. So we've talked about the 2 alpha drugs already. Let's go ahead and move into the beta 1 drugs. So we have metoprolol, which is a selective antagonist, and carvedilol, which is a non-selective antagonist. So with your alpha 1 drugs, phentolamine and tamsulosin, and with your beta 1 drugs, metoprolol and carvedilol, you're just dealing with antagonists, basically the ones that are dedicated to alpha or beta. You know, those are going to be antagonistic drugs, or in the case of beta blockers. Get to that here in just a second. But so metoprolol, being a selective antagonist of beta 1, whenever it is acting on receptors, it is searching out for that beta 1 receptor, and it loves to stimulate that beta 1 receptor. So metoprolol is used in a lot of cases to lower blood pressure. It also does a good job of bringing down the heart rate. So going back to what we know about beta 1 and its effect that it has on the ionotropic effect, then we can understand that if you're blocking the effect that's going to stimulate increase in heart rate and increase in the contractility, or the how hard the heart is pumping, then you know we're blocking those, and you're going to experience a decrease in heart rate, a decrease in blood pressure. And so you can go ahead and recognize that beta blocker for beta 1 is lowering the blood pressure and the heart rate in particular. So let's go ahead and throw all these on here real quick, and I'm going to abbreviate all of them. So we've got metoprolol, and let's go ahead and talk about carvedilol. So carvedilol is a non-selective beta blocker, beta antagonist, beta inhibitor. So when you're saying that it is a non-selective, it has the potential to act on both beta 1 and beta 2. The time when you would use carvedilol is again in hypertension. What you're looking for whenever you are giving carvedilol is again that blocking of the stimulation of an increase of heart rate and an increase of blood pressure. So the reverse of that basically is going to be a decrease in heart rate, decrease in blood pressure. But because this is a non-selective, it may or may not have an effect on the beta 2. And again, beta 2 is the lungs. So that's the agonist that we have up here for beta 2 is carvedilol. So when you are antagonizing beta 2, or you are inhibiting its normal effect, beta 2 again has a relaxation effect on the airways. It also does things like it has to do with mucus creation within the airways, but that's another topic for another day. So carvedilol being an antagonist, a non-selective beta antagonist, we have the potential for the airways to kind of constrict a little bit. Now, things that you would look out for with that would be obvious difficulty breathing, as well as like your O2 saturation. Those would be your nursing considerations for that drug, because you know that it has the potential to inhibit the regular action of beta 2. And then let's hit albuterol, and then we're going to jump back to norepi here in just a second. So albuterol is a beta 2 agonist. It is a bronchodilator. So what it ends up doing is whenever the albuterol is inhaled, it is going to have an effect specifically on your beta 2 receptor. And so it's increasing the effects that it has. So what that will translate to is a decrease or bronchodilation, a decrease in the constriction of those airways, and allowing for air to again move freely through those lungs to assist with respiration, or the free transfer of carbon dioxide and oxygen. So that one, albuterol, is a selective agonist of beta 2. One thing to note when you're researching these drugs, when you're figuring out side effects, adverse effects, albuterol does kind of have a systemic effect on the sympathetic nervous system, because the body recognizes a change that is consistent with a sympathetic change. And so as the body is adjusting to that, you might notice an increase in heart rate. You might notice jitteriness that's associated with an adrenaline dump or what have you, a sympathetic response. So it's not uncommon for albuterol to have those side effects, but it's the body's recognition of what's going on rather than the drug itself. So it's not particularly having an effect on any of the other receptors. It's really just hitting beta 2. So let's jump back to norepi, and we're going to wrap this all up. So norepi is the one that Dr. B called Levophed. So Levophed is really good for bringing up the blood pressure without increasing a heart rate. So a case where that would be necessary is one of those where you have a patient who is hypotensive, hypotension does not allow for regular perfusion to all of your organs if it's below a specific mean arterial pressure. And so it's important to keep that blood pressure up to make sure that everything stays perfused, to make sure that everything is getting the oxygen and nutrients that it needs to operate at normal capacity. But Levophed is acting on that alpha 1. And if we go back to alpha 1, we're remembering that alpha 1 has a specific effect on the vasculature throughout the body. So it's going to help increase that blood pressure by constricting peripheral vessels, pushing it all towards the core, and you end up getting dilation at the core, and that ultimately bringing more blood in and constricting it out to the periphery is going to raise that blood pressure. So it allows for proper perfusion without stimulating an increase in heart rate, which would be associated with a sympathetic response. And what I mean by that is if the blood pressure is low and the pulse is high, we are recognizing that the heart is pumping faster to accommodate for that loss in pressure. And so we don't want to raise that pulse more. I believe I said this earlier, that when you're pumping faster and faster and faster, it's not having a chance to fill up the ventricles and the atria and pump like it needs to get perfusion out to the rest of the body. So that's one of those indications for Levophed or norepi. And then I just realized I didn't hit the indications for tamsulosin and phentolamine. So with tamsulosin, one of the indications to use that drug, one of the reasons why you would use that drug, is with a condition in men known as BPH, or benign prostatic hyperplasia. So essentially the prostate is enlarged, and it ends up assisting in bringing the prostate back to a functional size. So common side effect of BPH, common thing that men deal with, is difficulty urinating. So we are activating that sympathetic response to allow for urination. And then phentolamine is used in high blood pressure, hypertension. Again, the way it's acting is by antagonizing that sympathetic response. So knowing that is an antagonist or a blocker of alpha 1, you can understand that it is blocking the effect to push blood to the core, and it's actually allowing the body to keep dilated or more dilated than they would be if they were acted on vessels in the periphery. So I believe that's all that I have for you in the way of drugs. I'd encourage you to go out and look through the PowerPoint again. Take a look at the side effects, adverse effects. Understand those. Understand the indications when to use these drugs, because they are going to pull that up on the test. I think we all saw it the last time. So if you have any questions, comments, concerns, please feel free to reach out to me. Several people in the class have my number.
but you can also email me at zspoindexter, POINDEXTER, at pstcc.edu, or you can reach me at a personal email, 865angler at gmail.com. Appreciate you looking over this video. If you have any questions, comments, or concerns, please drop them in the comments below. I'd love to hear your feedback. Tell me what else you would like me to go over. If I'm confident with it, I'd be more than happy to talk it out. But I appreciate it. If I missed anything, or if I had any kind of wrong information in this video, please drop a comment. I would love to correct that where I can. Thank you so much for watching, and hope this helps.